Good morning to everybody. We are going to learn about hernia today. So, what is basically a hernia is? Hernia is nothing but it's an abnormal protrusion of an organ or tissue through a defect in its surrounding walls. There are various sites of the body where hernia can occur, but we are interested in surgery most commonly into the abdominal wall hernia. So basically, we can classify hernia as external or internal. External means it protrudes through all layers of abdominal wall that is visible from outside with the naked eyes. And internal means it's a protrusion of the intestine through a defect within peritoneal cavity, and it is not visible to a naked eye. If you say abdominal wall hernias, according to its location, we can classify abdominal wall hernias into groin hernias, anterior abdominal wall hernias, pelvic hernias, and posteriorly occurring hernias. So if you see in groin region, we can identify inguinal and femoral hernias. Now, if you see anterior abdominal wall hernias, we can notice umbilical hernia at the umbilicus, epigastric hernia, and Spigelian hernia. If we notice the pelvic region, we can identify there obturator hernias as perineal hernias. And posteriorly, we can have lumbar hernias. So there is a Petit's hernia, what we can call it. Petit's triangle. Through Petit's triangle, we can have a hernia. Now, according to its contents, we can classify the hernia in three main types as a reducible inguinal hernia, irreducible, or strangulated. The term reducible simply refers to that contents can be replaced in the peritoneal cavity. Irreducible hernias where we cannot reduce the contents, and strangulated means where there is a compromise in blood supply of the contents of the hernial sac. So it comes in a complicated variety of inguinal hernia. The hernial strangulation. So it occurs when large hernia passes through small orifices. The small neck of the hernia obstructs blood flow, venous drainage, or both. The adhesions between the content and the peritoneum, they obstruct and strangulate the intestine. The incidence, if you say, is 6 lakhs per year hernia repairs are done in US. Most common operation performed by general surgeons. 5% of the population will develop abdominal wall hernia. Now, hernial incidence. 75% of all hernias, they occur in the inguinal region. 2/3 of they are indirect inguinal hernia. If you say sex-wise, gender-wise, male sex is more likely to have groin hernia than females, 25 times more in males as compared to women. In female, femoral and umbilical hernias are more common than inguinal. Now, if you see both inguinal, indirect, and femoral hernia, they are more common on the right side. Maybe delay in atrophy of right processes generalized may be a factor. Slower descent of the right testes to the scrotum may also be another factor. And temporary effect of the sigmoid colon on the left femoral canal may help its protection also. If you see the anatomy of the inguinal canal, it's a 4 centimeter in length, 2 to 4 centimeters up the inguinal ligament. It extends between the internal inguinal ring and the superficial inguinal ring. It contains spermatic cord in males and round ligament of uterus in females. Now, if you see the contents of the inguinal canal, they are spermatic cord, which itself contains rheumatic muscle fibers, testicular artery, pampiniform plexus, genital branch of genitofemoral nerve, vas deferens, rheumatic vessels, lymphatics, and processus vaginalis. Now, if you see the coverings or the boundaries of the inguinal canal, superficially there is external oblique aponeurosis. Cephalade, there is internal oblique and transversus muscle. Inferiorly, there is inguinal and lacunar ligament, and posteriorly, there is fascia transversalis. Now, how you clinically diagnose hernia? So, patient will complain of bulge in the inguinal region. he or she may also complain pain or discomfort. Groin hernias, they are not extremely painful. And sometimes they also may complain of paresthesias, which may be because of compression or irritation of the inguinal nerves. If you see the differential diagnosis of hernia, we can enumerate like this. It could be a femoral hernia, it could be a hydrocele, it could be inguinal adenitis, it could be varicocele, it could be ectopic testis, it could be lipoma, or it could be hematoma. Again, in differential diagnosis comes is a SOS abscess, femoral adenitis, lymphoma, metastatic neoplasms, epididymitis, testicular torsion, femoral artery aneurysm or pseudoaneurysm, and a hydradenitis of the inguinal apocrine glands. Now, if you see clinical examination, it is done in both standing and supine position. Visual and palpable inspection for mass in inguinal region is done. Ask patient to cough or perform Valsalva maneuver. Place fingertip over the inguinal canal and see from where it comes. Finally, fingertip into the inguinal canal. That is, clinically, we do this by ring in the vagina test. Can also identify the hernia. Now, sometimes if you don't examine the patient in standing position, bulge of the groin described to the patient may not be detected in supine position. And that's why all these hernias, they're examined in standing position. Investigation wise, if you see, you can order a sonography of the abdomen, which has a high degree of sensitivity and specificity in detection of occult, direct, indirect, or femoral hernias. You can also advise to undergo CT abdomen and pelvis to diagnose unusual hernias or atypical groin masses. Now, once it has been confirmed clinically as well as with the investigations, now what we will do further to manage a hernia? Usually, hernias, they are managed by surgery. There are no medications that will resolve the hernia. So mainstay of the treatment will be an operation. So operation is recommended on discovery. You have to see if the progressive enlargement and weakening of the tissues is there, there is a potential for incarceration and strangulation. These things you can advise the patient and you can plan operation based on these things. Now, in which patients you will not advise surgery in spite the hernia is there. So if you are expecting short lifespan of the patient is very aged, elderly, frail, or patient is having significant comorbid illnesses. In those cases, you can avoid unnecessary stress of anesthesia and surgery to these elderly people. So if you want to take a non-operative management in these elderly frail patients, what you can advise them to use? You can use trusses, etc. The complication of the truss will be slow testicular atrophy, ilioinguinal or femoral neuritis, and hernia incarceration. So one thing you have to remember when you are adopting a non-operative management is that you will not recommend non-operative management in femoral hernia because of the high incidence of complications, particularly strangulation. And now we come to main surgical treatment of the hernia. So what are the surgical techniques for the hernias? The three main types of inguinal hernia surgery, they are open surgery, laparoscopic or minimally invasive surgery, and robotic repairs. Your surgery and recovery will depend on multiple factors, including the type of hernia you have and how complex the surgery will be. So if you see the operative repair, uh, the anterior repairs are the most common technique. Tension-free techniques are standard. Now we'll see a small operative animation to understand the basics of inguinal hernia surgery. So this is a small animation. Okay, unfortunately now this small video, animation video is not running now. So we can go to the next slide. So what we'll discuss is basically the surgery is Bassini's repair. The inguinal hernia surgery name is Bassini's repair. It is named after the Italian surgeon Eduardo Bassini. So here we take a 4 to 6 centimeter incision in the groin crease. We dissect into the inguinal canal and identify the hernial sac. The hernial sac reduction. So that means the sac is gently reduced into the abdominal cavity and the tissues are repaired. Inguinal floor is repaired using sutures or mesh to strengthen the area. The incision is closed in layers. Now, this is original Bassini's repair. The main difference between the Bassini and modified Bassini's repair for the inguinal hernia lies in how the posterior wall of the inguinal canal is addressed. The original Bassini repair attempts to directly repair the posterior wall with sutures, while the modified Bassini repair, also attempting a direct repair, often incorporates modifications like high ligation of the hernial sac and sometimes even reconstruction of the inguinal floor. So this is a diagram which shows external oblique aponeurosis above, inguinal ligament, conjoint tendon, pelvic tubercles, spermatic cord, deep ring, and reconstructed. After reconstruction, it looks like this. So here what is done? Conjoint tendon, that is a together transversus abdominis and internal oblique, and the inguinal ligament. They are tied together by interpreted mattress sutures. So these are some slides which show the hernia. This is the Bassini's repair basically. We have taken an incision in the inguinal canal and we are dissecting now into it the spermatic cord layers. Now, this is external oblique aponeurosis. It is being opened. Now, this is a hernial sac which we want to separate it from the spermatic cord. Now, the sac is opened and the contents, they are reduced inside the peritoneal cavity. Now, the high ligation is being done of the sac and this procedure ends there. So, we'll discuss in short about Bassini's repair. So, Bassini's repair has been largely replaced now by tension-free mesh repairs such as Lichtenstein's and total extraperitoneal repairs, which have lower recurrence rates and less postoperative pain. However, Bassini's repair may still be considered in select cases such as small unilateral inguinal hernias, patients with contraindications to mesh repair, and surgeons' preference or expertise. It's important to note that Bassini's repair has a higher recurrence rate compared to mesh repairs, and long-term results may vary. Your surgeon will discuss the best approach for your specific situation. Now, coming to the next repair is the shoulditis repair. The shoulditis repair is a surgical technique used to fix inguinal hernias. It involves a layered closure of the abdominal wall without the use of mesh. It's well-established tissue-based repair that aims to reconstruct the posterior inguinal wall using sutures to overlap and reinforce the area. The technique is known for its relatively low recurrence rates when performed by experienced surgeons. The key features of the shoulditis repair are, it's a layered closure. The repair involves creating 4 layers of tissue flaps from the abdominal wall and overlapping them to reinforce the weakened area. Suture technique, continuous sutures are there. Polypropylene can be used. No mesh. Unlike some other hernia repair methods, the shoulditis original technique doesn't involve the use of surgical mesh. Local anesthesia. The procedure is often performed under local anesthesia. It can also be performed under regional anesthesia. The shoulditis repair is known for requiring a steep learning curve, an excellent surgical technique to achieve optimal results. The benefits, if you see, of the shoulditis repair, they are low recurrence rates when performed correctly. The shoulditis repair has shown low recurrence rates, especially for primary inguinal hernias. Faster recovery. The use of local anesthesia and the focus on tissue repair can lead to quicker recovery compared to some other methods. Reduced risk of mesh-related complications. As the technique doesn't involve mesh, it avoids potential complications associated with mesh, such as infection or chronic pain. Now, considerations of the shoulditis method are, first is a learning curve. The shoulditis repair requires significant training and expertise to master, and it may not be suitable for all surgeons. It's not suitable for all hernias. It may not be the best choice for all types of inguinal hernias, particularly those with extensive tissue damage or large defects. There is a potential for pain and swelling. As with any surgical procedure, some pain and swelling can be expected. during the initial recovery phase. In conclusion, the shoulder access repair remains a valuable option for inguinal hernia repair, particularly in the hands of experienced surgeons due to its low recurrence rates and focus on tissue repair without mesh. So these are the slides which shows layered repair has been done in the shoulder access repair. Now, just to enumerate, some other repairs are also there to repair hernia, that is Lichtenstein's repair. There are some other methods of hernial surgery are there. We just are enumerating there. Now, laparoscopic management will come to laparoscopic management of hernia. So it's minimally invasive, tension-free mesh repair. The less pain is there, quicker recovery, better visualization of anatomy, fixing all hernia defects, and decrease surgical site infection. These are the some positive elements of the laparoscopic management. The complication rate, if you see, is less than 10%. Recurrence rate is low, 0 to 3%. Now, what are the types of the laparoscopic hernia repairs? They are TAPP, that is transabdominal preperitoneal approach, and TEP is a total extraperitoneal approach without entering into the peritoneal cavity. Now, up till now, we have discussed what the inguinal hernia is and how to diagnose it, how the clinical diagnosis is there, and how we manage the inguinal hernias. Now we come to femoral hernias. So naturally, the name itself suggests that femoral hernias, they come through femoral canal. Superficially, if you see the boundaries, there's superficially the inguinal ligament, laterally the femoral vein, and posteriorly there is Hooper's ligament. So this is a diagram from where you can identify the femoral canal and the potential space from where the femoral hernia develops. Now, there is a mass or bulge which is below the inguinal ligament, and initially the mass or bulge starting below the inguinal ligament. So this will confirm or give a clue that it could be a femoral hernia. Later on, it can come over the inguinal ligament if the hernia sac is ascending. So it's usually more painful than inguinal because of the short space there. The repair of the femoral hernia is dissection and removal of the hernial sac and obliteration of the femoral canal defect. You can use Cooper's method. You can as well use mesh here. In case of strangulation, the hernial sac content could always be examined for via plate. Now, there are some special hernias. A small consideration is given in this lecture. So, to these things. So, one is sliding hernia. Internal organ comprises a portion of the hernial sac. Mostly, they are indirect inguinal hernias. It could be a content of the hernial sac could be bowel or urinary bladder. Danger is you have to remember that there is a visceral component of the hernial sac during operation to avoid damaging these structures. Now, recurrent hernias. So, challenging. These are challenging. Higher incidence of secondary recurrence. Placing the mesh is required for success. Recurrences after anterior mesh repairs require posterior approach and placement of second processes. Strangulated hernias. What will you do in strangulated hernias? Hernial sac contents must be visualized for viability. Constrictor can be incised to reduce tension. Sometimes it's necessary to resect strangulated intestine and anastomose healthy bowel segments. What are the postoperative common complications of a hernial repair? They are wound infection, hematoma, pulmonary embolus, hemorrhage, ischemic orchitis, and testicular arteries. So this was a small synopsis for the hernia. Thank you.